Um, Hi, everyone. I've come across another interesting case that I was hoping to share with you guys, and I hope you'll find it quite interesting. So it's a bit of a while since I've actually covered one of these. This was actually sent to me by our ophthalmologist, just as a teaching exercise. Um, so this patient, as you can see, suffered quite severe penetrating trauma of the eye, of the globe itself. And so we're just going to discuss a little bit of what to do when you find a patient like this in the emergency department. This was now actually after a few days. This is not an acute injury, but an acute injury would look similar to this. There's one piece of advice I always give the younger doctors when it comes to looking at the eye. And number one, you've got to know how to do visual field testing and things like that. You've got to be able to use your ophthalmoscope and be able to look at the back of the eye. You've got to be able to do, fundoscopy, of course. But over and above that, in the emergency department, because we don't often have the luxury of a dark room and of split lamps, if you do, that's great and you should use them. But the majority of us like working in a semi-rural setting or a rural setting. We've often got busy emergency departments. The lighting's not ideal. You can't exactly switch off the light so that you can do a proper fundoscopy. You can't do staining. You can't do slit lamp examinations, or anything like that. So often the only thing that we've got to go on is the exterior. And there's nothing wrong with that because sometimes you do need to be able to tell quite a bit from the exterior as well. So what I always advise people is have a system. Number one, either you look from the inside out, or you look from the outside in, but make sure that you cover each and every area so that you know what's going on. Now, in this particular one, if we just cover it like that, we can see that there's no trauma, luckily, to the eyelids, either superior or inferior eyelid. The lacrimal duct punctate here seems to be intact. We can't see the conjunctiva, but we can assume those are okay because there seems to be a direct blow here onto the cornea just there. We've got a little bit of a pterygium that's forming on this side, although that could just be a bit of subconjunctival injection as well. It's difficult to tell from this. And then once you come to the iris and the cornea and what you call it, a bit of the sclera here at the bottom, that's when it becomes a bit interesting. So one of the questions ophthalmologists will often ask you is what type of an eye is it? And your answer is basically, is it an organized or disorganized eye? Now, in this question, it's disorganized. The reason for that is you can see that parts have become separated, parts are extruding. So in fact, here, this is a vitreous humor and aqueous humor that's actually started to protrude from there. It seems as though you've got protrusion of the iris as well as the pupil through this area as well. You've obviously got this cut that's run through, although slightly healed in this photo. You've got a traumatic cataract that's going on over there. If you were to see this fresh, you may not see the cataract. However, you would see the disruption of the pupil and you'd see the extrusion and the so basically the herniation of the contents of either anterior chamber or posterior chamber as well. We can see here that the cut has also affected the lower end of the sclera. And when you get this type of a view, you get this sort of like a darkish flap that goes through, that often indicates penetrating globe trauma. So what that means is that it's gone into the posterior chamber as well. It tends to give you this picture, So there is a medical reason behind it. We're not going to get into it right now. It'd be nice for you to go and check up and see how come penetrating trauma actually gives you that look that it has, So it has to do with your retina and how it forms and its function and things like that. But in any case, so after a few days, this patient had developed this traumatic cataract. This is a disorganized eye. There's nothing that can be done for this eye. It can't be repaired at this stage. Now, my understanding, the history that I got is that the patient had a sharp object fly into the eye while he was working, not wearing safety goggles. It actually flew in, just penetrated in. He was unable to open the eye when he came in initially, and he was seen by the ophthalmologist. He was a referrer from a local district hospital. and they were struggling to even open the eye. So if you have the ability, of course, you can put in anesthetic drops. And if not, then you give high dose painkillers to enable you to be able to get rid of that, what they call blepharospasm, which is where the patient just shuts their eyes absolutely tightly. And sometimes if you don't have access to that and you do need to peel these back, my advice is don't place pressure on the eyelids itself. So what you do is you get a paper clip or something equivalent where you can make a little blunt hook. And then you place it underneath here, and you place it underneath here, and then you slowly retract. Paper clips work very well, and because they're quite blunt and they're quite small, it's very difficult to cause trauma to the eye. The main reason why you don't apply pressure is that you're trying to preserve whatever humor there is in the anterior and posterior chamber. And of course, once you apply pressure and you've got an open wound, you're just going to force all of that out and basically decide the fate of this eye before the ophthalmologist has had a chance to look at it. Now, in this case, there wasn't much hope. In fact, you can see, the eye is quite flattened. A lot of the humor had leaked out. And sometimes when the humor does leak out, you actually get your eyelashes getting sort of like a film on them, especially with vitreous humor. It tends to have that type of effect. Just a little trick just for you to know. So if you start seeing these, it almost looks like pus on the eyelashes, but there's no history of infection, but rather of trauma. You need to start suspecting that there's vitreous humor that's come out over there. So once you have opened this up and you've had a look, then you need to be able to describe to the ophthalmologist what's going on. So what this is a combination of things. So you've got possibly a little hyphema or scleral cut over here. You've got an obvious corneal cut and penetrating corneal cut through the iris, through the pupil. You've got extrusion of the anterior chamber contents, possibly even posterior chamber contents. And you've got a bit of iriodialysis, which is separation of the iris from the musculature here at the end. So, you've got all these things that you need to have a look at. Now, for those of you who may be wondering, okay, how do I learn all of these terms? Where do I learn all of these terms from? I'm going to link the video that I've done previously on ophthalmic trauma, as well as a link to a checklist that you can use when you are dealing with eye trauma, so that it assists you in it's just a good revision and something you can go back and have a look at. And, hopefully it will help you with your patients in the future. Now, of course, you need to take as close a look as possible. Now, this is not the best image that you're ever going to see, I'm sure. Sorry to enlarge it like that as well. But especially in these types of scenarios, you've got to look for any associated injuries. So especially, along this side with the tear ducts and tear gland, things like that. There's often injuries to the eyelids and the tarsal plate and so on and so forth. But the main thing is that you need to describe to the ophthalmologist exactly what's going on. And what I always tell people in the emergency department is that other departments would only listen to you if you kind of speak their language. You don't have to speak exactly like an ophthalmologist, but they need to know that you know what's going on. So as compared to telling an ophthalmologist, well, I've got a patient with a penetrating injury to the eye, could you please come and see the patient? Okay, I'll think about it. It's not really an emergency. Admit the patient. Is very different from, doctor, from what I can see, it's a penetrating globe injury. The patient has got extrusion of the anterior chamber and posterior chamber contents. The sclera seems to have been disrupted. There's leakage of vitreous humor from what I can see. The lacrimal duct, the lateral canthus, medial canthus are intact. Eyelids are intact. Majority of the sclera is intact, but the eye looks flattened. And we've got herniation and protrusion of contents. This prompts the ophthalmologist to realize that, okay, this person knows what they are talking about. So maybe I should come and see. Or alternatively, the ophthalmologist, because, they may well tell you this, and of course you tell them this is a disorganized eye. Unfortunately, for a disorganized eye, it is very difficult to sort out. It is possible, but often very difficult. At least they may move on to the to saying, okay, send me a picture. Let me see how bad it is. Maybe we can arrange a CT. Maybe we can arrange an ultrasound of the eye if you have facilities to be able to do that. So ultrasound of the eye is actually a very valuable tool in this case. So the patient would have a close closed eye, and you'd put a large amount of gel and then place well, you need a high frequency probe, not the abdominal probe that we use, but you use your high frequency probe and just lightly touch the gel, and it would actually give you a good picture of what's going on in the eye. So, is there still a foreign body that's retained? Can you see if there's any retinal detachment? Things like that. So, you can see the optic disc. There's quite a bit that you can see with the ultrasound. CT also, to a certain extent, can tell you quite a bit of what's going on. And your management from an emergency department point of view is, number one, you're going to give antibiotics, not topical. You are going to give systemic antibiotics. You're going to keep this eye covered. So either with an eye patch or something that you can use. Now, in our emergency department, we've often run short of eye patches. So what we have done in the past is, actually taken a cup and a polystyrene cup and cut it off so that you're just using the top half of it. And what we would do is then actually cover the eye in such a way. I don't know if this would work. Oh no, it's not going to work. My apologies for that. But we're not really sure how to do it over there. But we would take a polystyrene cup and cut it so that roughly the circumference would more or less cover you about 2 to 3 centimeters away from the border of the eyelid, or even 1 or 2 centimeters, and then tape that down so that there's no pressure, there's no air movement, because there's hyperesthesia of the eye as well. So all of these things can assist you. If you are lucky enough to work in an area that is well resourced, you would place a steel eye pad over this until the ophthalmologist has a look. Steel eye pad is perforated. It protects the eye completely. It doesn't allow debris to go in it, but it allows air to pass, and it really is something worth looking at. Worth using for an injury such as this. So this patient, unfortunately, had an enucleation of their eye, and that was the end of that, unfortunately. So I hope you guys will refresh your memories with the other video that we had done quite some time ago, and keep the checklist, or at least bookmark it, so that if you do get stuck with the eye trauma, you know what to do. Okay, thanks a lot. Bye.